testicles, unlike the transvaginals, but you can't use the wipes on them. You have to use like a wet towel or something just to kind of clean them off, but you can't use because it will degrade the plastic, whatever. That being said, so when you guys actually scan a patient, the penis is going to be flipped out of the way. These ones, I don't know why they molded them this way, so as the students have been flipping them out of the way, they have gotten giant holes in them. So just be sure that nobody's getting like ripped off penis in those, okay? And these are about $9 grand a piece. Believe it or not, for what they are. I know I'm in the wrong business.
How much is the female?
They're about $7 grand, like $7,500. I know, it's like, wow.
I just
okay, so we're gonna go to, let's go transducer type. We're gonna go on the linear, and we have a small parts thyroid, small parts superficial. We're gonna go small parts testicle. I forgot gel. Some students in the past, because the testicles, I mean, they're not lifelike, but because they kind of move around, some students will take like a stack of towels and just kind of stick them here. I'm usually one who will just kind of like hold with my fingers. I'm doing this. Out in the real world, the patient would be a little bit higher and I actually rest my arm on them. And it's just easier to kind of do things. That way you're not kind of like, you know how you've done the transvaginals, your arms are out and they kind of probably get fatigued. So as much rest as I can. Okay, so. Real quick. All right, so talk to me a little bit about our protocol.
transverse.
So we're gonna start with Sag. Think about your thyroid. What do we do for thyroid?
I thought we started in transverse.
Yep, Sag right. Sag right, and I just put Sag right. If they don't know that you're scanning a testicle, they need a new job, right? Because it's a testicle ultrasound, so I just do Sag right. If you want to do testy on there, totally fine with me.
Wait, don't we start in transverse, not thyroid?
But I just meant like the protocol itself.
Oh, okay.
Like we have a medial, like the kiddies, we have a medial, the lateral.
Okay.
Oh my god, my blood pressure is going up. I don't know. Okay, so we're gonna start with Sag right. You guys all see?
Yeah.
All right, so now remember our longest length is going to be our sagittal. On these machines, I'm not gonna have you guys stitch or anything, but I will have you do the wide scan just to accommodate the whole thing. So we're gonna sweep through this, sweep laterally for pathology, sweep medially for pathology. I expect there to be some artifact in these, same as the others. And if we go to the left side, there's actually a pathology in the left side. So when you guys are doing these next quarter, if you choose to do the skin, and you get to have some optional exams next quarter, if you choose to do them, you will need to document that. So our longest length, Sag right, and freeze. And I'm not gonna save these or whatever because I have them printed on the board already. So our first caliper is gonna be superior to inferior. I'm not even gonna push the button, we're just gonna, just do it. Our second caliper is gonna be the AP. Again, we would have that tunica albuginea and the tunica vaginalis. In this case, we're only seeing the tunica vaginalis, so we're just gonna put that right on the edge. We don't have an albuginea to include. And then there would be our second image. So next we'll go out to the lateral aspect, or you could do medial first, up to you. So lateral, sweeping through for pathology. Now, oh, I'm in the most lateral. This is what Shea wants to see. No, this is not what Shea wants to see. She wants to see some meat and potatoes. So kind of showing me a little bit more of that actual testicle itself. Moving into the medial aspect. And with these models, you have to be careful. So it starts to get this artifact, and if I keep going, I end up in the left testicle. So I'm actually in the left right now, so even though I'm on the right. So you just want to make sure you're not going too far over with your imaging base. So there's our most medial. Let's see if we can get some artifact out of the way. Contact, we're going to squish on him a bit. So there's our medial aspect. And then we're ready for our color. Now, because we are doing superficial, we can actually have our color box covering the whole testicle. So we want to make sure top to bottom of the testicle is included and as much superior to inferior. We're going to walk through with our color. We're looking for any abnormalities, kind of like with the thyroid. You may not see a mass that's isoechoic, but its vascular pattern may kind of catch up to us. So nice and slow, kind of moving through that testicle, and then we'll take a representative image. In this case, low velocity is kind of what I'm trying to get you guys to show me. So low velocity, where your box size is. Next up, we're going to use pulse wave. And of course, we don't pulse wave. But I want to see that you're not putting it like, oh, here's where I'm sampling. Like, what are you doing? And I didn't tell the class yesterday this either. Sometimes when we get these really large fluid collections, these large hydroseals, and you put color on them, they'll actually have kind of a swirling pattern. And it's not because it's vascular, it's more just like the circulation of the fluid within that hydroseel. So don't be fooled that you're like, holy shit, like this thing's crazy. And then an update button. And just to show me again kind of where your scale's at. I wouldn't want to see your scale like this, 100, right? So just showing me a kind of representative of where our pulse wave would be and what our scale would be. And then next up, we're ready for
Or
transverse. You got it, transverse. So we're going to close our wide scan. We're going to center this guy. Normal testicles are a little bit more rounded than this. These ones are kind of almost triangularly shaped. So we're going to make him kind of the star of the show. We're going to put that right. We might see a little bit of left in there. So our first image is going to be right towards the mid. Caliper. And I'm going to have you guys do this directly across. Even though it's wider at the top, these are going to be circular out in the real world. So kind of get used to the idea that you're going to have this in the middle. So there's our second image of that transverse right. Sweeping down that inferior to see if there's any pathologies. Coming back and taking a representative inferior. And then moving up into our superior. Going all the way up through that testicle. Taking a representative image of that superior. And now we're ready for the right epi.
Can we decrease sector with these?
Not on the linears.
Okay.
Linears don't do that. Yeah, you can do it on the other ones, but linears don't have that. And so, because they just are straight down. So, sag right epi. And we're going to optimize to that epididymal head. In the real world, you're not going to see the body going into the tail this cleanly. And so if you choose to scan the models in class, I don't have you guys worrying about the epi body or the tails because they're kind of too obvious. But out in the real world, or if you do a real scrotum, practice finding that epi body and tail because they can be a little bit trickier. So we've got our sag right epi, we've optimized to him. He's going to take one 2D image and then a caliper from superior to inferior, just straight across. And then we're also going to do a color evaluation, so making our color box a little bit tighter on him. So color evaluation, and then a pulse wave as well. And what should my waveforms look like?
Low velocity.
Low resistance.
Oh, resistance.
You're right though, it is kind of a lower velocity because it's just kind of a hill. You know what I mean? It's not, we don't have that big spike with systole, but we want forward flow through diastole, so it's very similar to the ovarian wave. Well, they're identical to the ovarian waveforms, which are identical to the testicular waveforms. Pardon me?
Above baseline.
Above, well, it depends if you catch a vessel that's going towards you or away.
Okay.
So it doesn't matter whether it's above or beyond. In some of them you'll see, like you see with the ovaries, they actually have it on top and bottom. So it's not so much that it's above or below, that's just direction. But the idea is that with systole, we have an increase in velocity. It could be down here, increase in velocity, and then forward flow.
If we have mirror effect, do we need to get rid of it? Or
Nope. Nope. Okay. They don't care about it for this. Like if we had it with, when we're trying to do real directional stuff, we're trying to get absolute velocities like carotids, hepatopedal, hepatofugal, then we would. But for stuff
Okay.
like this, they don't care.
Got it.
So I'll take this image just to kind of show you guys, but it's not this easy to get out in the real world. But we would try to get, so our epi heads here, we would try to get body and tail kind of in one image. It can be a little bit more challenging than that out in the real world, but then we would also take that image as part of our protocol. Then we would go over to the left. So sag with calipers, medial, lateral, sag with color, sag with pulse wave, go to transverse, mid with calipers, superior, inferior, going back to sag to optimize to that left epi head with calipers, epi head with color, spectral, isolating that epi body to tail, or maybe need a couple images out in the real world, and then we're going to do our bilaps. So we're going to, these are the ones I have to go like, okay, everybody get back in the bed here, you know, like I need you there. Okay, so bilaps, open sector, again, we want to have about the same tissue represented, so I don't want to do something like this, right? I want to make sure I have at least similar representations of size of tissue. I'm going to do a 2D evaluation. So there's our first image. And then our second image, we're going to measure the skin line. So we're going to do AP directly above that particular testicle that we're looking at. And we don't have that tunica abuginium to worry about, so we're just going to go from the very, very top of our skin line to the very, very posterior aspect of that tunica vaginalis. Same thing over here, skin line to tunica vaginalis. And then we're going to do a color evaluation of the violets. Looking for any hyperemia in one or any hypoemia, what would that be, hypoemia, if we have a torsion. We take a representative image as well. Now we don't do this here on the models, we don't have it, but out in the real world, I would then go up to my right inguinal canal, I would take an image with and without Valsalva, and just kind of peek around for any abnormal lymph nodes and do the same thing contralaterally on that left side.
Is that where you saw the lymphatic cancer indications?
That's where I find lymphomas, yeah. I've found about 4.
Wow.
That way.
Stacks or transverse or doesn't matter?
So you're gonna, when you do the pinform plexus evaluation, you're going to be in transverse because the spermatic cord's going this direction.
Yeah.
But when I see a lymph node, then I'll be like, hey, what's going on over here? You know, sagin transverse on that particular lymph node. Is there neighboring nodes that are abnormal, things like that.
Okay. Above 1 is abnormal.
Are you sure? Dr. Sam told us, but actually it's in different area, different standards. For
Every literature, but
for
2 millimeter change is considered varicocele. Yeah. I think that's what the book says.
No lymph node.
Oh, lymph node. Oh, lymph
Lymph
nodes.
node.
Oh, that's goofy because lymph nodes take on all different kinds of shapes and sizes. So you guys have probably seen some normal ones along the jugular, but because they're so long and lean, they are over a centimeter.
Okay.
But they're normal. But now if I saw one that was over a centimeter and a half in the axilla, where they're supposed to be nice and roundy, then I would worry. So it really depends on where you're at. And the appearance makes a difference. So hyperemia or not, do they have that echogenic fatty hilum? Are they losing that? Or is the cortex still, intact or not? So there's a bunch to it.
Okay.
For our exam, do we have standard, like 1 centimeter standard? For when we take exam for license?
I don't know. It's probably going to depend on what literature you read for it.
Okay.
I have never had the second year students come back and say that, oh yeah, they were definitive on
Okay,
this.
gotcha.
I think if anything, they'd probably ask you, what are the things about an abnormal lymph node? It's going to be more appearance related.
Yeah.
Any other questions, comments?
She's
All right, well, I'm going to turn you loose. We've only